Like to welcome everyone. As folks are coming in from the waiting room. It's great to see you all. We're going to get started in a moment. Okay, so a moment has passed. I'd like to welcome you all to the Building a Culture of Community Engagement speaker series. Tonight, we are thrilled to have with us a team from the BMC Health Equity Accelerator. Our objectives for this, and I should say that I'm Linda Sprague-Martinez. I co-direct the Community Engagement Core for the Boston University CTSI with my colleague Tracy Battaglia, who I'm going to turn it over to in one moment. I'm a faculty member in the School of Social Work. Our objectives for this evening are to discuss systems change at Boston Medical Center that are designed to advance equity and to share strategies to engage community so that we're ensuring access to equitable care at Boston Medical Center. And we're thrilled to have our panelists with us that my colleague, Tracy Battaglia, will introduce herself and introduce the panelists now.
Unmute, rookie move. Good evening, everyone. My name is Tracy Battaglia. I am so thrilled to be here with all of you. As Linda stated, I am the co-director of the Community Engagement Program for the BU Clinical Translational Science Institute. I am on faculty at the School of Medicine and in the School of Public Health. I'm a primary care general internist and breast health specialist at Boston Medical Center and health services researcher, really passionate about engaging all of our diverse stakeholders in the process of research to advance the health of our population. And so it is really, truly my distinct honor to be able to introduce our panelists to you this evening. I'm going to be very brief in my remarks in introducing them for you. You can see we have a very dynamic group of amazing female leaders who are really blazing the way in Boston and beyond to help us achieve health equity with our populations that we serve at Boston Medical Center and our health system. Elena Mendez-Escobar is the Executive Director of Strategy and the Executive Director of the Health Equity Accelerator at BMC. Dr. Thea James is the Executive Director of the Health Equity Accelerator and Vice President of Mission and Associate Chief Medical Officer at the Medical Center. And Petrina Cherry Martin is with us as Vice President of the Community Engagement and External Affairs at Boston Medical Center. So we are delighted to have them join us today. I think they're going to get started with us by introducing us to the Health Equity Accelerator at Boston Medical Center. So I'm going to turn it over to them to make some remarks before we engage in dialogue. So thank you all for being here.
Thank you for having us here today. We are, I don't know how many people are or how familiar people are with Boston Medical Center, but, you know, Boston Medical Center has been here since the 1860s. And, you know, it was a hospital that was intentionally built for the people of Boston way back then. At that time, Mass General was the hospital that was here and was running out of capacity. And so and then we had a lot of immigrants here, you know, from Western Europe, for example. And, you know, I've read the whole book on the history of Boston City Hospital, and I'm just like reading from the book, quite frankly, although I'm looking at you, I just know the book. But we are the largest safety net hospital in New England. A majority of our patients are BIPOC patients. A majority of them live at or below the federal poverty level, and about 35% of them, for them, English is not their first language. And so if you imagine, probably what comes up in your mind is a certain profile, but I can tell you for decades, we have been addressing the gaps that our patients have, and we have been creating and designing all kinds of programs, many of which have been disseminated around the country. And, you know, we've been leaders in this space. And next slide, please. Even though we've done all this work, it doesn't change the data you see right here. This just is persistent, predictable. I mean, if you think about it, you all probably know something about these titles here, but no matter what they put up there, whether you know anything about it or not, if you measure demographically, I think you already know who is going to do worst. And so that, in fact, that and, what we came out of COVID learning, which was more deeply about some of the structural causes that lead to these types of things, led us to do some deep work that led us to develop or form the Health Equity Accelerator. Next slide, please. And so one of the first things we did when everyone was, making commitments and things to equity, we didn't do that right away. We sort of paused, not to do nothing, but we paused to do this work right here. The first thing that we did was to take an internal look across our entire enterprise, covering all the areas that you see on the right. And what we were doing on that deep dive is looking for disparities, looking for inequities across the entire enterprise, which is not easy to do from the perspective of it can feel awkward, for example, but we set up some principles and things to guide us through this so that there'd be no blaming, no shaming, but only supporting each other as we went on this journey. The first thing we did was 80 leaders, like chiefs of departments and people like that, were brought together. And as we looked at all the data, we were divided into 6 groups. And each of the groups identified areas that they were going to work on, things that they were going to do over the next 6 to 12 months, or I'm sorry, next 12 to 24 months. People are held accountable. We have absolute dashboards that we track, and we have meetings regularly where people are reporting on what they had identified as initiatives they wanted to work on. Now, these are initiatives we're working on, but what we committed to doing was having an enterprise-wide or health system-wise transformation. And not just like doing projects and things like that, but to transform the way that we actually do things. Next slide, please. And this is what we came up with. The Accelerator, and our intentionality is to transform healthcare, to deliver health justice and well-being across a number of things that Elena will identify for you coming up next. Next slide, please. So this is how we started. This is the 3 of us, as you can see, and the Equity Oversight Group. And from this point here, Elena will take you forward to bring you up to where we are now at our 1-year anniversary.
Thank you, Thea. And it was actually yesterday, our first official anniversary. So we're really excited to be celebrating that with you today. So what is the Accelerator? In a nutshell, where we landed after that process that Thea was describing is this. Our goal is to transform healthcare to deliver health justice and well-being. And how the Accelerator does that, essentially 2 ingredients. 1, intentionality, to look at racial and ethnic disparities very explicitly, talk to Black patients, talk to Latino patients, understand what they want very, very intentionally. And number 2, breaking silos. So we already have a lot of great ingredients in our system, excellent clinical care, innovation. We are lucky to be an academic medical center and have research and education and a great community engagement relationship that Petrina leads. So putting all of those things together in multidisciplinary teams really empowers us to get much deeper, much faster in what's driving, what are the barriers really for health equity, and what can we do to change them. So we prioritize the 5 clinical areas below: pregnancy, and pediatrics, infectious diseases, behavioral health, chronic conditions, oncology, and ESRD. These are the areas that in our data we saw have the largest inequities. And I have to say they're pretty consistent throughout the country. Unfortunately, we're not that special. These are really the areas that show up again and again across the country as showing the highest areas of inequity. So this is where we're focused. Over our first official year with the Accelerator, we have been able to launch initiatives in 4 out of these 5 areas. And we've also been investing, actually with many of you who are on this call today, on building out core functions and enablers that are needed to be able to accelerate this work. Whether it is our data and analytics infrastructure, our HR tools for training, building a culture, hiring diverse staff, and promoting diverse staff, our community and patient engagement pieces, our social determinants of health and investment in our community, research, education, advocacy. All of these functions have been building out intentionally health equity capabilities, adding resources, and really make our system much stronger to be in a different place to really address health inequities. Here are some numbers just from the first year of operations. Equity in pregnancy and COVID are the two initiatives that are most advanced in implementation phase. You've all heard about the great work we've done together on COVID vaccine and equitable distribution of the COVID vaccine. The equity in pregnancy team has already launched a remote monitoring program that has been very successful in providing our patients with information and agency to be in charge of their own care. And we've also launched recently equity in diabetes and cancer with funds, and we've been hiring up those teams as well. So really excited to have been able to launch so many different fronts even through our first year. Some other data points below, as you can see, I think I want to point out specifically two pieces for you. First, our commitment to engaging with our community, our patients. This number here, it's really exclusive to patients that we've engaged for health equity projects. We have engaged 15,000 patients through multiple surveys, interviews, focus groups. We're constantly engaging with patients in community advisory boards. It's really important to us to engage our community in a meaningful way. What we didn't want to do is just add a patient to our board and call it a day. Instead, we're constantly reaching out to patients in forums where they are the majority to help us design what should be our priorities, design interventions, and truly work together with them as we evolve in all of these. And because of this audience, I also want to highlight the research keys we've been building out slowly to add some connections to all of the great resources that already the BU BMC campus have around health equity, around research, to connect people doing work on health equity to those great resources that we already have so that they can evaluate and publish the work that they're doing. So over the last few months, we have a program of 3 large grants and 9 smaller pilot grants that are that we've distributed. And we've also been building out our health equity research team. So we recently hired a manager, a qualitative method specialist, and a quantitative method specialist. And we have also hired recently our director for health equity research, who will be joining BMC early next year. And this team will be working with all of the different people across campus who are doing health equity work and wanna evaluate it and publish it, and we'll be connecting them with resources like what CTSI can provide, as well as others to facilitate that collaboration and that cross silos work that really characterizes the accelerator. I just wanted to give an example of how many resources we're putting behind this. All of these people have been hired over the last year to support all of the different priorities. And it's not just the people that you see here today or even on this slide. The work of the Health Equity Accelerator involves so many of you. You'll see some of your photos here as well. And this is what we could fit on a slide. But what's exciting is that this is already the work of all of us. It's engaging so many people, and we can see already even just 1 year, we're just getting started, but 1 year in, the transformative language and intentionality that we all have around these topics, talking about race, talking about health equity, and really not hiding away from any of those difficult conversations. So the passion of all of you here at BMC and BU to really advance health equity is really, really exciting. And with that, we wanted to wrap up this part of the presentation with 5 lessons that we've learned in our journey so far, that we think are very translatable to any other areas. And we wanted to touch on them briefly, and then maybe we can go deeper in the Q&A session. Thea, do you want to start? Thea, you're speaking on mute.
Sorry about that. I think one thing that, that we recognize is that our patients are in perpetual states of low health status. And I think one of the things that, we've kind of known, but one of the things we know for sure just through talking with people and the various different conversations we've been having with people is that they are not able to prioritize health because survival supersedes that. So if they're having limited resources, they're actually going to use those resources for survival, like feeding their families, paying rent, keeping utilities on, and that type thing. And so oftentimes, we are just treating them and then resetting in the baseline and discharging them back to what's driving it all. So we have had an intentional focus on economic mobility, economic stability, even not only in patients one by one, because we have, for example, a pipeline program with patients coming from 7 zip codes around us that we serve into jobs at BMC. And they're not just focusing on jobs per se, but thinking about the the living wage, the Boston living wage, and also focusing on making sure that they're able to get engaged in programs inside that provide professional development and mentoring for them to rise through the ranks. HR department already has a couple of programs there, one for upskilling and the other one pathways programs, moves people from entry-level jobs into manager jobs. And we've also done some sort of just as an example, external sorts of investments, like in small business. And, we've talked a lot about the Nubia markets that we have. And that particular example is one where we were removing a structural barrier to enable people to create wealth because it's in a location that most banks would not want to finance. And so we removed the structural barrier because they wouldn't just be able to have the store because they wouldn't get financed by giving them a no interest loan and giving them a long time to pay back so that they would have enough time to generate revenue to be able to pay back comfortably. And the other thing is they were initially tagged as operators. And we were wondering why they should be operators. I mean, why should the store be a job for them versus an asset for them where they can build wealth and generational wealth? And they also represent an example of how there can be economic, other economic and BIPOC economic engines to create thriving local economies. And so the bottom line is our patients cannot prioritize their health when they are prioritizing survival. The other thing is time is luxury. Our patients' lives are complicated. There are a lot of things that, they have to do and to get done. A lot of things are not efficient for them to do. And so they often don't have the time to prioritize health. For example, when we were trying to find a way to help them avoid the cliff effect, for example, getting them into housing, higher jobs without losing their affordable housing, 17 out of about 19 of them signed up to want to participate. But over time, they sort of fell off of the process because they had other things that were taking priority. So we recognize that time is luxury as well. And in our equity and pregnancy program, we created something that addresses that as well so that people don't have to come into the hospital, take time out of their busy lives to get treatment and to get checkups. Elena, you want to take the next one?
Yeah, so number 3 is this idea of agency. We talk all day long about needing patients to trust us, wanting patients to trust us. And what we learned is that for that to happen, we need to trust them also. So we're really shifting to share a lot more information with our patients, creating more extensive and culturally responsive educational materials on different conditions so patients can have agency over their own health and make decisions. The Equity in Pregnancy team has been developing new education around preeclampsia with a group of patients, telling us, what questions they've had, what things they would like to be able to find answers to, and it's been a really incredible journey to be able to do that with them. Number 4, timing is everything. We've seen that a lot of inequities are really coming from delays in diagnosis and delays in initiation of treatment, especially in areas where there's no standardization. And when it's not well defined how long something should take, it ends up taking longer for Black patients, for Latino patients, and so forth. So within this one is very actionable for any really discipline. Just thinking about a department, what is a condition that there's a lot of variation on when it's diagnosed or when the treatment is initiated, and putting a goal around that in itself, that can help dramatically reduce inequities. So that's another one. And then the last one, averages are blind, averages don't work, and unfortunately our health system, our care guidelines nationally are catering to the average. And for example, when we were getting ready to launch the cancer initiative, I talked to a number of people in other hospitals to get their advice, and everybody said, without a doubt, do not prioritize prostate cancer. That's not a priority. People do not die of prostate cancer. And that is true in general on the average population, but it's very much not true for Black men that have a very high rate of prostate cancer deaths. So that's just an example of how we need to cater to the patients that we have here and shift a little bit. I see this a little bit like the transition that we've had with television, moving from an era where there were 5, 6 networks and broadcasting, and all the programming really had to cater to the average American and be very generic, to today. The explosion of television has come from streaming, being able to create products that really are targeting very niche populations that have very specific needs. And I think in healthcare, we have to make that transition as well, right? From broadcasting to streaming, and to really define creating products, experiences that really are catering to the specific needs of the different groups of patients that we serve. So these are still very generic lessons, but I hope it's a good start to the conversation, and happy to take it where, in whichever direction would be most interesting.
Wonderful. Thank you. Thank you so much. You blew me away with the moving from broadcasting to streaming. So critical, right? How do we meet people where they're at? There are so many ways to do it. And you've answered some of my questions. We're going to move now into just a Q&A, and then we'll open it up to the audience. But as you were talking, I heard of so many different organizational change strategies that you're putting in place. Like, you're really shifting. You're not just changing the way you do things, you're changing that overall thinking. And I'm wondering if you could talk a little bit about that process, the process of shifting an organization to move away from practice as usual to this new way of practicing what you described as across silos, and getting, because so many of our organizations are broken up into silos, and that's the way we structure ourselves. And when I heard you talking and saw your visuals, I'm really seeing this kind of cross siloing you're trying to build. Can you talk a little bit about that process and some of the strategies you're using to shift change, and maybe some of the things that have helped with that process? Maybe there are roadblocks. What are some particular some lessons you've learned through those specific organizational change strategies you're putting in place?
I'll start, and then I'll let Thea and Petrina weigh in. But I think that is the hardest piece for sure, and we know it will take time. And the one thing that we have going at BMC is the energy, and that we are so aligned on the mission, and people are so committed to the mission. I had a question recently. Someone asked me, how do you motivate people at BMC to do this work? Sometimes, off the side of their desk, when they don't have time, they're already stretched. And I said, you know what? We really don't have that problem. Everybody is so motivated and so uniquely committed to our mission. That really makes things easier. But it's hard to, do things in a way that we're not used to. It's we don't really understand maybe because we've never done it that way. So it's a little bit of learning by doing, and no one really has the answer. No one is, there's a little bit of humility on that as well. We don't know what's the right way, but we set up a set of principles of how we were going to engage with each other early on, and committed to trying it out and learning by doing. And, you know, I think we've already seen from the COVID work, the pregnancy work, to now diabetes and cancer, that is getting a little bit easier. Because we're all getting so much practice, and you know, it's been now an official year, much longer, that people have been trying to do this. So it's a little bit of just having the willingness and the humility to try something different and be committed to it and learn by doing.
I think the work that we did around COVID is likely the best example of just non-silos whatsoever. I wish I could describe to you. So if you guys remember how crazy everything was, it was at the beginning of when the vaccines first came out. We were all obviously virtual, but to have meetings every day with almost every department, from operations to clinical to nursing, every department you can think of engaged in a meeting to figure out very quickly how to set up six sites in the city of Boston. And so I think what we learned from that whole experience has carried over into other things. So the work that I do in community engagement literally touches every department at BMC. It is very essential to the success of our health equity work. And so, you know, from hosting a community conversation or a community-based event, or working with a research team on how we're engaging the community in research, it's been great to see, you know, each and every department jump in and pitch in their own way. In research, working with CTSI and CRN and all the different research departments to make sure that as we are engaging the community, we're doing it in a very thoughtful, coordinated way. And so I think these are the things that make our success in health equity, and it makes the way that we're engaging the community so successful. So.
Yeah, I also, did you say something, Elena? Oh, sorry, I thought you said something. I also would add that, you know, when we started out, as Elena said, you know, we started out with, this was coming from the top. This was coming from the, you know, the most senior leaders in the organization, you know, so, you know, everybody was absolutely involved. And I mean, you know, I mean, we started out with, in a very, very difficult way, you know, I mean, starting out by, instead of making an equity statement, first thing we did, you know, just as I said earlier, is just looking inside our own house. And so, you know, we started out being inclusive and collaborative and supportive and that type thing. But it was a top-down sort of initiative, or transformation, I should say.
Great. Thank you so much.
I have the privilege of the next question. I just want to make a comment to the audience, though. I want to encourage folks who are on the call to open their cameras if they like, and to be active in the chat and start asking your questions so that we can make sure we hear from all of you. So I have so many questions that I'd like to ask. I'm trying to stay on script, but I heard words like intentionality and community, and, you know, internal and external. And so, you know, we're here representing the community engagement program for the Clinical Translational Science Institute. And, you know, at the core of the work that we do, it's sort of partnering with communities. And so I wonder if you could each speak to the approach that you took in identifying your partners, and, you know, with intentionality, and, you know, where do you start internally and externally to identify your partners? You gave some really great examples of some of the partners that you brought in, but I wonder if you can just describe your process or approach.
I'll start. Leading with intentionality is this, you know, it's the common theme here, but two things. And I think one is being very mindful of who in the community, what community-based organizations, what community leaders were already doing the work. And so, you know, when you talk about health equity and changing the trajectory of people's lives, that's not something that one organization can do on their own. So, you know, we partnered with trusted voices in the community who have been doing this for the work for generations. So faith-based institutions, community health centers, community-based organization that had a track record. And so we, in many cases, were coming along to say, how can we just help to link these organizations? If you look at, I'll keep referring to the work we did at COVID because it was significant, but it was a situation where you had a health system, BMC, working with churches, working with community health centers, working with you know, boys and girls clubs, all connected on one common goal. And so I think as we move forward in this work, we look for opportunities to do just that, connecting with folks who have a track record of, you know, successful work, and they have trusted voices. When we go into the Haitian community, for example, it helps to go in with a Pastor Kiki or an agency that's been serving the Haitian community for a long time. It gives us, you know, it helps us build trust in that community. And so I think that's the thing that works. We've been very intentional about building community advisory boards for all of the work that we're doing. So whether it's maternal child health, behavioral health, and that's important because as great as of an effort that we're all doing, like we can't work harder or we can't care more than the community cares about themselves. And so everybody's heard the term, you know, those who are closest to the issue should be closest to the solution. And so that is the approach that we take when working with the community, making sure that the first thing that we're doing is getting feedback and guidance from them in how we approach the ways that we are trying to build equity, health equity in the community.
Thank you, Trina. I wonder if at the core of what everything that you're saying is sort of trust and, you know, trusting in those partners that they have the solutions. It's that agency that Elena was talking about before. Can you talk a little bit about the internal community and the internal partners? Because when you know, your slides so eloquently sort of, you know, demonstrated, you know, how you pulled all these groups in diversely across the hospital. Having been here for 22 years, it's really heartwarming to see, and it's felt across all the different departments. And I just wonder if you can speak to that process a little bit.
That's great to hear from you, Tracy, being in so many of our initiatives that we touched. But I think the same principles apply around when we're building trust with the community, with our patients or with internal stakeholders. To trust people, for people to trust us, we have to trust them, right? So when we put together a multidisciplinary group, making sure that we are creating the space for everyone to bring their value to the table and their voice to the table is not a you know, it's not a show participation, it's real participation. And, you know, that's not easy. And sometimes it may feel that it's not the fastest path. It may seem, although we believe that it does end up being the fastest path because we get much better results together. So I think it has been just start walking together and showing by doing that we can all be in multidisciplinary teams where we have so many experts across the system. A lot of people call BMC, I don't know if you've heard this before, the land of hidden gems. There's so much expertise, and I still keep learning about things that I didn't know. And every time you open a door, only something better is going to come from the conversation. So the more we talk and the more we connect, the more obvious it becomes that that's the right path.
I would say one other thing also is a transformation to this level of intervention, like this level of this far upstream, this far upstream is looking at sort of like systemic ways in which things happen, and how we might be even inadvertently complicit in it. And the whole notion that some of the things that we see and expect, including the data, is so much the status quo that it appears like the natural order of things, like the norm. And so in the beginning, sometimes it can be challenging, and thankfully everybody's so collaborative. You can talk to people, you can have conversations with them, but people are might be inclined to propose something that is very similar to what we were doing pre-COVID, for example. You know what I mean? Might just be something that is just going to identify a disparity of some sort, versus something that is has an intentionality to eliminate that, but that being the ultimate goal. That is a mindset shift, and it's in the beginning, hard to get people to understand that. And what I will say, as a person of color, the perpetual studying and showing and talking about disparities in and of itself is traumatic. It's just traumatic to just keep showing how horrible things are. And there's like, it's expected that that's going to be that way. And nobody is doing anything to try to understand how it got like that to begin with, And so nobody has any intentionality to like disrupt it or have a goal to eliminate it. And so that I would say has been, one of the hardest things. But again, luckily, it is a collaborative culture, here, and you can talk to people and, be civil and that type of thing and be encouraging and supportive. But, that's a challenge in the beginning for sure.
Thank you all for those remarks. Linda, would you mind if there's 2 questions in the chat that relate to sort of the partnership? Is it okay if I pull those out before you move on to the next?
I just wanted to make a comment,
Oh,
and
yeah,
then I'm gonna go over to the chat next. Thank you. No, I just wanted to appreciate that comment that you just made, Thea, because I think that that's one of the biggest harms that we often overlook in terms of how we approach communities in such a deficit-driven way, looking for what's wrong, constantly telling us what we have. As what we don't have or what we're missing, as opposed to all the assets that we have. So I really appreciate that. And similarly, I think, Elena, you made a comment earlier that was so spot on related to averages, right? Because average is meaningless. It's just a bunch of points divided by a number, and that no one is really average. And so I appreciated that point as well. And I think that what you're doing is really kind of pushing us to think differently, despite the fact that funders are asking for things in a certain way sometimes, where it's easy for researchers to kind of say, okay, let's look what's missing. So I just wanted to really appreciate and elevate those points that you made. And then I was going to jump right over to the chat, because a number of folks, thank you all for putting in these comments, or putting in some great questions in the chat. And the first one was from Angela, who asked this question of how do you overcome the challenges of time commitments in your community and the partners and patients advisory committees, and preventing heavy drop off when life gets in the way. So if you can see that comment that came in. And Angela, if I butchered your comment, chime in. I'm looking for you on the screen right now.
I think people are really busy. And so with our community advisory boards, we try to, really, I would say stack our advisory committees so that there's always a community presence. But I mean, it's a struggle. I mean, anybody who is working with, with any organization knows that there's a point in time when your super volunteers are overcommitted. And so those are the people that you want in your advisory boards. You want people who are really involved, but sometimes those are the people who are overly committed. So we try to make sure, and we're dealing with that ourselves. So we're trying to make sure that, you know, we are in every meeting, keeping it fresh and giving them opportunities to talk about the work that they're doing in the community. So you have to be really creative, because you're right, to keep people engaged, especially busy, overly committed people. It takes a lot of creativity. So I think the one thing that we are definitely doing is making sure that they see the work that we're doing. So if they come to an advisory board meeting and they're contributing, we want to make sure that they see that the information that they're giving us, their you know, intellectual capital and their experience, it lands somewhere and it's really affecting the work that we're doing. So we're hoping that people find value in that and that they keep showing up.
Thank you so much. If no, I don't know if any of the other panelists also want to comment on that, or if I should move over to the next audience question.
Maybe the only thing to add is the piece around internally. How do we do it? And I think it's very important to resource these efforts. This should not be work that people are doing off the side of their desk, on their evening time, on their weekend time. Like, if we are serious about this being core part of how we work at BMC, it has to be resourced in that way. So we've done a lot of work. I think I showed the slide of all the people that have been hired. Most of them not in our team. These are resources in other functions across the system, whether it's analytics, whether it's HR, whether it's the research team. So to truly give them the capacity to be able to do this work in a meaningful way. So we think that's really important, to be able to resource. And we also put this in our advocacy work, and you know, the way things, healthcare services are reimbursed, and the way payers reimburse us, and what is valued from a financial perspective needs to reflect these needs as well.
Great, thank you so much. One of the next questions we have from Diane, and you spoke a little bit to really the importance of your mission, but how are you working through conflicting agendas or priorities among institutions or within the institution and community partners? How are you, what's the process that your group is using for that? Because oftentimes there are conflicting agendas.
I don't know who wants to take that, but I would say our priorities are not conflicting. I think everybody in the community has the same priorities. There are just too many of them.
Yeah.
So it's more about picking where do we start, but we really haven't found that much. Once we pick something, people are excited to pursue it. Like, there's just so many priorities. I don't know, Thea, Trina, what would you say?
No, I agree.
Yeah, I agree.
There's never not too much to do. We also roll pretty hard around here. That's the other thing. I mean, it's just, you have to have your skates on around here. You know, really. Things happen fast. People work hard, and you know, it's something. It really is something. It's the culture, you know. It's the culture of the place. But at the exact same time, you know, it's not one of these rigid cultures where people have handcuffs on you and, you know, won't let you be innovative and creative, won't let you do stuff that's not been done before. You know, it's the opposite of that, in fact. So it's sort of like a school without walls or whatever. That's been good. And I know that all healthcare systems are not like that. You know, I work with a lot of colleagues across the city and other states too, but in particular in Boston, and it's just not that way every place.
I agree, Thea. It's absolutely amazing to work for an organization where at the highest level, we get the opportunity to really just go build it. And so the support that we have with just building it. So whether building it means, you know, creating this amazing accelerator where we're able to do just some groundbreaking work, and then have the resources from the entire organization. So whether that's from, you know, clinical or our analytical teams, just to make sure that we're doing the work and we're doing it right. But no handcuffs is an amazing thing, especially when you are doing transformational work and you are, working with communities. It's that part is thrilling. So this is why people come to BMC to work, I think, for the mission and to be able to be engaged at this level. So it's good stuff.
Yeah.
It's great. Wonderful. Next, we have the question from Kimberly that asked, based on the growth of the Health Equity Accelerator in the past year, what areas do you believe will see the most change in the upcoming year?
Was I certainly hope pregnancy outcomes, diabetes control, and cancer screenings. And we have so much hope in those that we put it into our corporate goals. Reducing diabetes inequities is in our corporate goals for the years that will determine executives' compensation. So it's a tangible goal of reducing the gap of A1C control, Black patients versus white patients. And that's how committed BMC is to achieving it. So we know this takes time, especially things like pregnancy, where we don't really know exactly. There are no proven interventions that we just have to execute and are gonna work. We're trying to innovate, so it may take some trial and error, but we certainly chose the name Health Equity Accelerator for a reason, and we're hoping that through the next year we can start seeing some of those health outcomes in those areas, really started to change.
Great. Anyone else want to add to that before we jump forward, or? Since I failed sitting with silence, we're going to jump forward. All right. So the next question comes in from our colleague, Rebecca. And what advice would you give other hospital systems who want to accelerate equity for patients in the communities where their patients live?
Thea, you want to start?
She said, the question was, what advice would you give people who are, wanting to start things in
Other
community?
hospital. Yeah. Other
other
hospital
hospitals?
systems. What
Oh,
advice do
yeah.
you have for other hospital systems?
Well, we tell them we tell them the exact same thing. We tell them to engage the patients. I mean, most hospitals, medicine is rigid. Most people don't step outside the hospital. Most people, just think about it. Well, I don't know, everybody here is not a doctor, but like when you're in medical school, you're taught like, essentially you're taught to focus on disease, right? And how to like treat the disease. And there's this level, and when you encounter people who have a disease, you treat people with that disease, and it doesn't go right. The last thing you think about is, what could I have done better? That's not what you're taught to do. There's just like, people generally say, oh, they're like non-adherent patient, that irresponsible, doesn't care, didn't take the medicine, whatever. But the last thing you do is wonder what you may have had to do with that. Did you ask the right questions? I mean, the simplest thing to ask about something like that is to ask the patient. And it took me like all these years of working in the ER. And eventually I would ask people, particularly people who come in with the same thing over and over again. I was asking them one simple question: what would it take for this to never happen again? And, they'll tell you. I don't know why people think they won't tell you. They will absolutely tell you, and sometimes, they'll just say things like, I don't, they don't have enough money. I have to do this. I couldn't get a ride. I couldn't do that. I mean, there are reasons why, and so I think we kind of like get in our own way, when we just make assumptions about stuff. And I think the most dangerous piece about that I've witnessed in my own career is somebody taught that to us, and then we teach it to other people. We teach, and when you're doing things like changing shifts, you got students and you got residents at every level, and they're just like soaking up all that stuff they hear, and they're just like passing it on. Like somebody doing shift change and somebody saying to me, there's so-and-so in room such and such gaming the system. They're starting off the sentence that way. And so when people say stuff like that, I ask them to like substantiate that. what do you mean by that? Because there are all these younger people, listening, and they're not necessarily younger chronologically, but younger age-wise, but younger in training. So I just think it's one of the best ways that we can start to like change all of these things is in medical education. I mean, because that's kind of like where it starts, even if it's not medical school, any allied health field, anything that involves you engaging, with human beings, so yeah, the answer to that question is, I would start with the patients, start with the people, start with the community, ask them, they will tell you. Trina was able to lead all that work that well by reaching out to them and asking them, how should we set up vaccination sites? Where should they be? What should they look like? The strategy team and the operations people, they worked on this together. They would walk through sites and look at these places and set up the operations and stuff. And so it's just not something that is taught, in medicine. And we sent out surveys. That's how we knew the patients were hesitant. We saw what percentage of them were hesitant to take the vaccine by demographics, even internally in the hospital, the staff, same thing, so I would just say, just ask. So if you want to engage with the communities, ask them any and everything. They will appreciate it, to be honest with you.
Great points.
Yeah, I love everything you said, and it's so true, because I've actually know people that have, gone through the system. And as I put it on the chat, I think, sometimes we take for granted the complexities, of coming through a health system and listening to understand. So you shared so many valuable experiences here. I'm curious if there's an opportunity for us to bring this back to, the medical school curriculum, to really, integrate this within the medical education, because we obviously have a great need here to prepare our next generation of physicians.
Yeah. Yep. Yeah, so true. Well, this is actually post-medical school, but all of the, every year we have orientation, hospital-wide orientation for new interns. They've already finished medical school, but new interns and new fellows. And we do this thing with them every year. So they have to learn the electronic medical record this first year, week of orientation, and they learn about patient quality and safety and the medical record. What we're talking about now in terms of orienting people to patient engagement and all this type thing, community and all that, is also on that list. And I think we're probably in our 5th or 6th year now of doing that. And so, and it always gets high ratings. So, because we want to establish how they think and how they approach patients before they ever get to sit in front of a patient here.
Great. Thank you so much. I have, we had 2 questions. One, Rebecca, you had your hand up a moment ago, and then also Lydia, you had your hand up. So I just want to make sure we get your questions in, and then we're going to transition to the next part of the program. Rebecca, did you have a question that you want to chime in, or?
Thanks, Linda. I couldn't find my unmute button. Thank you, Thea, for that response to my question. A follow-up to that question is to, I wonder if you could reflect on, from like a health system, a hospital perspective, about what it really takes to make this type of change happen. And some key points that I've heard during this discussion are leadership. I've heard all Trina, Elena, and Thea talk about how this really came from the top down. And I've heard that from other organizations that have had transformational change, that leadership is really important. Funding was the other point that you made, that the that the Accelerator was well funded. And I wonder if there are other resources that you put in place. I think that, having Trina with the community engagement piece that could make those external connections seemed really important. And I ask this question because our CTSI works with many hospitals. And as we think about how to share not only what BMC has done, but potentially how other hospitals could do this, I think it's really important to know that those kind of key ingredients. So I don't know if Elena or anyone wants to comment any further, but I really appreciated the discussion that Thea started in response to the initial question.
Yeah, Rebecca, I think you nailed it. Definitely, all of those are really important. I think the point around leadership commitment, honestly, that's the only reason I even took this job. I was a consultant before for 10 years, and I've seen so many organizations where diversity, equity are a sideline priority. They just name someone, but there's no real support or commitment to it. Then you're just constantly battling an uphill battle, and it's impossible. So if the top leadership of the organization is not really committed to it, it's really difficult. So I think that's definitely a key here. And the other piece is the community engagement. I don't know that others can replicate it, honestly, but it's been incredibly critical for us. The funding, it's one of our top priorities, continuing to advocate for that, fundraise, and truly resource this work as it deserves. But I also want to say, different organizations, when you're talking about how do I talk about this to other organizations, they're in different points, and not everyone is an academic medical center like we are, and not everyone needs to really, it's not either all or nothing. I think there's a lot that you can do by just getting started, and I think a lot of organizations had a little bit in analysis paralysis and, trying to understand the data better. And I made reference to this earlier. Unfortunately, none of us are that special. I'm sure things that we have found around pregnancy and preeclampsia, you don't need to rerun the analysis. You're probably doing that too. And remote monitoring would help you too. And sharing more information with your pregnant patients would help you too. So there is a big part of when we talk to other systems of, start somewhere that is already going to have impact for sure. And it's not an all or nothing approach.
Thank you, Elena.
I also think every organization has organizational culture too, just to put, throw that out there. We talk to different organizations, and I was on a panel today with people from other places in town, and they asked us each the same question, and people had a different response based upon organizational culture. Like some healthcare systems would rather, the way their commitment to equity would be to pay organizations to work with the community versus them directly working with the community. So it's sort of like, everybody has their own culture around it.
Great point. I'm gonna take Lydia's question, and then I'm gonna turn it over to Dima.
Thank you. It kind of like a question and a comment. So based on what Ms. Thea was saying, as far as asking your patients, I am a patient of BMC. About almost 6 years ago, 6 years would be Christmas Eve of this year. I had basically took myself to the hospital, and they found out I had autoimmune hepatitis. It occurred in one day. And I was the type of person that never trusted the hospitals, never trusted the doctors, because at that moment, you would hear so many different things, and other people's experience. It was just like, I don't want to go there. So it took me getting sick to end up in emergency. And then I realized 6 years later, almost 6 years later, I've built up relationships and I trust my doctors because I know they have my best interests. And my doctor at the time was Dr. Michelle Long, but she's no longer there. She continued her research. And now my doctor there is Dr. Lowe. And he's in the gastroenterology department. So all my doctors are pretty much a team. They work well together concerning my situation. One doctor is not going to do anything or give me any meds without checking in with my other doctors, because they know, which made me feel like, wow, they really have my best interests. And, you know, I have had people say, oh, well, try this hospital. And it's like, no, I'm not leaving BMC. You're crazy, you know. And me also being a resident leader for almost 10 years around my community, and also on the board with MCCPA, which is Mass Creating Community Power Association. We look for organizations like this to try to bring to our residents or people that work with us, just so they can grasp on and get a better view or more information on how they can have access to certain things. So I think trust is a big part of, without trust, there's no relationship, you know, and never mind a continuous relationship. And I just, you know, appreciate what you all are doing. And I just hope that you guys have more meetings that I can attend and spread the word to. So I just wanted to say that, based on my own experience. Like I said, it wasn't really much of a question. It was just, you know, what the question came and what Ms. Thea said. Me having those relationships with my doctors have played a tremendous role in my getting healthier and healing up slowly but surely, but it worked out. And I really appreciate the work you guys are doing.
Thank you. Thank you. Thank you so much. Thank you so much. Everything you're saying is so important and appreciated, and we're grateful for it. And I hope that your voice remains here, that you and when we're not getting it right, that you tell us, you let us know. Absolutely. We want to know.
Absolutely. Lydia, I just sent you a note in the chat. We'd love to have you on our community advisory board.
Exactly.
I sent you my email. So if you are interested, actually, if any of you are interested.
Oh, wow, that's great. Definitely. I'll let me just, I got to take a picture of it because the chat keeps scrolling up really quick, but I'll definitely reach out to you.
Yep. If you don't find it, email Dima after. She'll send it to you. She'll make
All
that
right, thank you,
connection. She'll
guys.
make that connection. I'm
Thank
going
you
to
so
turn it
much.
back over to Dima now because I ran over again. Go ahead, Dima.
No, there were.
I'm glad I ran over for that comment. So.
I agree. And there are so many questions in the chat that we still didn't get to. So I want to, I was typing them in the chat as well, but during the 6 to 6:30 portion of today's speaker series, we usually kind of keep the groups open to continue the discussions that were being had. So I invite you all to stick around. We'll have this main room for the for continuing kind of conversations with Elena, Thea, and Trina on the Health Equity Accelerator and community engagement. And then we'll also open a couple of breakout rooms if people want to go in and network with each other, kind of get to know who else is coming to these Building a Culture of Community Engagement speaker series. And then a third room to go, and if you have any resources that you want to share, you want to talk about. So I will do that. And I'm not sharing my screen, my apologies. But I will kind of show that. So let me open these rooms and then kind of continue. Feel free to stay in here, continue asking these great questions and having these conversations. Sorry. Linda or Tracy, if you want to continue taking questions. Okay, the breakout rooms are open if anybody wants to go in.
I'm muted, but I will continue here in the main room with the questions in the chat, or folks can feel free to throw up your hand. We can just go around that way too as we go, but there were a couple of questions that came up in the chat that we didn't get to. I think have a lot, and we also have a lot of kudos to the group and for doing amazing work. There was one question that I saw earlier. I didn't memorize it exactly, but I can't find it again now. That was really talking a little bit about thinking about those broader determinants of health and the work you're doing. It was referencing the role that poverty plays in the community, wealth and equity. And Thea, you touched upon it a little bit when you were talking around some of the focus areas you've had, but I wonder if you could talk about a little more about some of the work you're doing to kind of address those broader determinants of health in the community.
So most of the work that we have done has been with organizations who help us do these things. For example, when we're doing investment kinds of things, we've been able to do that through philanthropy and something called determination of need, which is when your hospital bills onto its facility, the state says you have to give 5% of the total construction cost to the community. And so we first did that in 2017, and we focused that on multiple different housing initiatives in the city, working with neighborhood development corporations like Codman, for example, Nuestra, Comunidad, the Community Builders, TCB, as well as Madison Park Development Corporation. And that involved various different projects, anything from renovation of a building, which is what was happening with Codman, to placing a community health worker and a nurse in Smith House over in, with Madison Park. That was designed to make sure that it's elderly housing, to make sure that people were able to be stable and not have to be hospitalized and things like that all the time. And the one at Community Builders was very similar, but the largest investment we made was with Nuestra Comunidad, investing in, I would say, it was Bartlett Place, used to be an old bus depot, and then they built what's 323 units of new mixed income housing, some to rent, but also some to own. And that was intentional because, you know, the ownership piece has opportunities to build wealth. And also what we invested in was actually a private equity fund as well, but it wasn't like the usual private equity fund. This one had some real intentional health scores to it. For example, if you're a developer and you present a proposal, whatever you propose to develop has to provide opportunities for employment and green walking space and transit and healthy, affordable food and affordable housing. So along with those units to rent and to own, also 70% of the people who worked on that project came from the community. So that was, you know, investing, economic opportunities into the community. And the grocery store, you know, came along as a piece of that as well. There's another project called City Fresh Foods that, for folks who are on the call who are from Boston, you might know of City Fresh because it's been around for over 20 years and provides these really, really delicious meals of and culturally appropriate meals for people. And when I say people, there are things like after school programs, there are daycare programs for elders and things like that. And they had been using the building they have for 20 some years. Their rent increased by 150%. And, you know, if they weren't going to be able to continue on that way, they have about, I'd say over 100 people who work, who live in the community, who work there. They even provide equity stock ownership opportunities for some of their employees. And so they needed some gap funding. So they had some normal kind of financing models to, you know, finance this building they wanted to buy across the street. But, you know, those normal financing models have high interest rates. They require people to pay back really fast. Sometimes companies can go under trying to meet those obligations. You know, they're worse off than they were before they got the loan. And, you know, it causes some businesses like to close. And so we made a commitment to, give them some gap funding, again, using a model that they could easily, follow comfortably. We talked to Children's Hospital, they made a commitment. We even talked to the City of Boston, Office of Economic Inclusion, and they made a commitment. And one of the housing departments too, Sheila Dillon's office, also made a commitment. And then beyond that, the city actually gave them a $17 million contract for Boston school system. So all of us, added to the capital stack, and they were able to pull this deal across the line. So now they have bought that building. So every, kind of opportunity like that. But again, we're also collaborating with, other hospitals who are in that space right now. By the way, so when we had that determination of need, we had $6.5 million to spend. Not a lot of money compared to Children's Hospital, who at the same time had 53.4 million, and they did invest with us. Now Mass General has one right now for 68 million that they have to spend on the community. So we're trying to like collaborate and work together as much as possible, in this space. So, and I think I told you at the top of the hour about the pipeline program we have too. I think I told you about that from the 7 zip codes.
Amazing, amazing work and direct work, but then also the work that you're doing to get people to work differently and partner. And
Right,
that's not
exactly.
something we've seen. So really wonderful. We have a question here. I got seconded on it. So Lamont Smith had put a question in the chat. And just really thanking you all for having this conversation with us tonight. And Lamont had asked, can BMC change their strategy on how it shares these types of works? Many of us are not aware about some of the great work initiatives that are happening. And so how can we get the word out more about these things? And then the second question is, what role can community health workers and patient navigators play in supporting these initiatives? And is BMC engaging with them? So those are two different questions that came in at the same time from the same person that were seconded by a few other people who wanted to hear about them. So if you could just speak to that a little. Elena, I see you came off mute.
Yeah, no, thank you so much for that feedback. We really want to engage with everyone at BMC and not just to share what we do, but to learn from you and partner with you. So if we haven't gotten to your team yet, would love to meet with you and learn more and about your ideas and what you're seeing in your everyday work and how we can continue making progress on this. One tactical thing I just put in the chat, we have a mailing list and a monthly equity innovation forum that is open doors and anyone can attend. It's the first Thursday of the month at noon. The next one, December 1st, is going to be a full hour update of our equity in pregnancy work. So I really invite you all to attend if you're interested in being on our mailing list and the Health Equity Innovation Forum invite. Just send an email to that email address that I just put in the chat and we can loop you in. But really, we would love to engage with as many people as we can across BMC. There was another question there.
I'll add to that, and I don't know, I think the question came from somebody who said they were a navigator, and I'm not sure which organization you're with, but we're always looking for people to join us in the community. So me and the community engagement team, we are constantly boots on the ground in the community. And so if you would like to join us or find ways to take the information about BMC and the work that we're doing, or if you know about places where we haven't been yet, but we should be, like, those are the things that we want to hear back, because it is definitely our goal to, consistently be in the community, engaging with community members. So my email is in my little frame, petrina.martin@bmc.org. And if if you have any ideas on how we could be or should be partnering with you or community members, please reach out.
And the other question was around how we engage with social work and community health workers. That's such a core part of the health equity work. And, Thea, maybe you should talk a little bit about that since you lead all the Thrive work. But yes, that is essential. Primarily, we do a lot of work with Thrive through Thea. There are also a number of initiatives, on equity in pregnancy. It's a lot of work with the Birth Sisters program. In equity in diabetes, we're actually hiring a few navigators dedicated to that team, and cancer as well. Some of the pilot grants that were submitted that are working on this year are working on navigators. There is one in particular working on the NICU with lactation consultants that are also trained to be navigators. So that's always a top priority. And again, if you have ideas on other things that we could do on those spaces, we'd love to hear them.
Right. And the Thrive work is primarily, for the most part, internal, because it's a screener that we have for our patients, where we screen them for any gaps they might have, and also give them the opportunity to identify things they want to work on. And we're sort of trying to up it, like make it a 2.0 version right now that makes it better, that there's more like direct interaction and that type thing between the referrals and us and them, like to close the loop. So it's been incredible though. I think one of the most useful things we've learned from Thrive is that in the beginning in 2018, when we created it, honestly, I remember having to advocate strongly to put, in terms of things that people had gaps in and wanted help with, were education and employment. And, when you look at it now, people, those two things rank as high as food and housing, and sometimes higher for what they want, because they know that those are pathways to, not having issues with food and housing, So it's been incredibly informative, for us.
Great.
I imagine our comms team is going to help us a lot with these type of things too, Elena, as we and Trina, as we're, they're building out new communications. We have a new marketing VP, and she's building up her team, and they're doing a lot on helping us with communications and branding and all types of things. I think that's one of the most common questions, like, we hear from people, is how can they get involved? People always want to know that, particularly like students and stuff as well. They all want to know.
That's great. Excellent. Any additional questions for our panelists? Don't be shy. Tracy Battaglia.
Thank you, Linda. So this is such a great conversation. In the spirit of the CTSI and research, I wonder if I can ask a research related question. I will acknowledge that in your slides, you had a blank member of your leadership team from the research side. That has not stopped you from making some really great advances in the sort of the research arena. I wonder if you can just speak to sort of what your vision is for the accelerator and research.
Yeah, and we actually have to fill that position.
Great.
Yeah, we've hired a health equity research director. She'll be joining in February. She has deep expertise methodologically, but also in adapting research for community engagement, for health equity insights and effectiveness. And she's great. We're so excited. And I think we, wanted to recognize there is already a huge ecosystem of research capabilities, including all of the CTSI, but CRN, there's just so much. Many of you are here, and the accelerator is not, it wouldn't be good use of the accelerator's resources to try to replicate that. Instead, what we're trying to do is be a little bit more the glue or the connective tissue with the people that are doing health equity work that are so dispersed throughout the organization. There isn't a department of health equity like there is an OB-GYN department that gives some cohesiveness to that group. So our goal with the equity research team is to be that connective tissue between people who are doing health equity research or work and all of the capabilities. And there are two ways we think about research. I think there is the more traditional way, maybe the most obvious one, people who are on a research path that are pursuing their K awards and so forth, that need mentorship and support in developing their careers and shaping their research. That's one piece of the work. And there is another very important one in our mission to break silos, which is BMC is full of great innovators. The Health Equity Accelerator teams are constantly developing insights and new interventions and things to put out. But the people leading that work are oftentimes not researchers themselves. They don't have dedicated time for research. They don't have the training for research. So we also want to support those groups to give them resources to be able to evaluate their interventions, to write about it, to give them the methodological expertise that they may not have to do so. So we have that double goal of supporting people in a more traditional research path, but also enabling people that traditionally would not have been able maybe to publish their work, but are doing great innovations in health equity to get that published as well.
Excellent. Excellent. Sorry, I said it before. I said it before Tracy was about to say excellent, I'm guessing, but I couldn't help it, came out. I just want to thank our panelists from the Health Equity Accelerator tonight. You've been so generous with your time and really coming with us to share your story. I'm looking forward to the spread in the globe about the Health Equity Accelerator and the journey that you've been on, because it really sounds like a movement that you're making within the healthcare and really starting at home and really beginning to partner outside. So really exciting work. Are there any final words you want to leave us with this evening? Things that we should know, ways to get involved, other than everyone's going to be emailing petrina.martin@bmc.org. Any final thoughts for us?
I just want to say thank you. And when we talk about our partners who are committed to this work and who really help us every day, I count CTSI among some of the best. And so thank you so much for being such incredible partners. And thank you for having us today.
Same thing. Same thing. You guys have, I feel like we've been talking to you since the very beginning, to be honest with you. So thank you so much. I echo what Trina said. Thank you.
And I just want to end by saying that the accelerator is all of you. It's not us telling you, it's really all of us across campus. We are the accelerator. And if we have worked, some of you, we've already worked together very closely, with others maybe not yet, and we look forward to doing so. And I'm sure many of you are already doing great health equity work that we haven't learned about it yet. So we'd love to hear about it. Love hearing, Lydia, your story. So we're all in the same team, and we really thank you for the work that you do every day to advance health equity.
I muted myself. Thank you all so much for a wonderful evening. I will just want to remind everyone that next month, we're with you on the third Thursday of every month. And next month, we are very excited to be bringing to you our colleagues from the Center for Anti-Racist Research. We're going to hear from Rachel DeCruz and Grace Gamez, who are with the advocacy the advocacy group within the I just thought there's different programs within the Center for Anti-Racist Research. So they're the advocacy program. They're going to be talking a little bit about the connection between community engagement and anti-racist research, right? And how we can really advance anti-racist research through community engagement. And so we look forward to seeing you all there. We'll be sending you lots of reminders. And we'll look forward to seeing you.
Thank you. Bye-bye.
Thanks, everyone.
Bye.
Great
Thank you.
discussion. Have a wonderful night. Happy Thanksgiving.